zone lymphoma. So it's outlined as initial treatment, first-line treatment, and second therapy. So what you can do really in the first line is observation and the radiation, excision, and antibiotics. I do commonly use antibiotics first just to give a trial, not because I think those patients are positive for Lyme disease, but also antibiotics work anti-inflammatory, and they reduce significantly the infiltrate. But many patients are fine just with observation, and then intralesional injections with steroids is highly effective. So if the lesions is really larger, so radiation therapy should be applied at low doses, so up to 20 gray. That's effective. There's no need really to give high dose, such as 36 or to 46 gray. So in multifocal disease, you still can watch and can treat if it's more like for cosmetic purposes. I had a patient who didn't want to be treated. He had 21 lesions. However, when he came back 2 months later, the lesions were gone, and I asked him, "What did you do?" And he said, "Nothing." And so that also kind of shows that this disease is more also in evolution and can change, at least for the marginal zone lymphoma. So, so for multifocal, you can give intravenous rituximab. It's usually given 6 cycles every 3 weeks. And topical therapy can also be applied, but so for the second therapy, second line therapy, again, still can be all the same, that for the initial therapy can apply for the second line. You still can watch, even if you had treatments and patient relapse, you just can watch. You can radiation, most commonly applied, intralesional steroids, excision, although sometimes physicians actually question, is this completely excised, the lesion, and I can never really say if the lesion is completely excised, because there's always lymphocytes in the skin. Even if you biopsy a normal skin, there's always a mild perivascular lymphocytic infiltrate, so how can you determine if that a lesion is really completely excised? But it's also not necessary. So for multifocal as the second line is more like the multi-agent chemotherapy, could be R-CHOP, is most commonly applied. But there are modifications of R-CHOP as well. So, I show you a case how you should not treat a patient. And I saw this recently. This is a young boy. He's 6 years old. I found he was the cutest boy ever. So yet now at age of 4 he developed cutaneous lesions. And there were biopsies. He had 4 biopsies in the past. All 4 biopsies showed findings consistent with marginal zone lymphoma. And there was molecular assay was also done and showed IgA rearrangement in 1 biopsy. So he was treated with R-CHOP 6 cycles. And he was in remission until January, when we saw him this year with recurrent disease. There's very subtle changes here on the arm. And then on the face, on the papule. This is a close-up of the papule. So, and was referred for a combination of Rituxan and bendamustine. So this is a treatment that's commonly applied for follicular lymphoma, actually to achieve long-term remission. And it works very well. It's an aggressive treatment, and it works very well for systemic disease. However, it's not recommended for primary cutaneous marginal zone lymphoma. So this is one of the biopsies that were submitted for review, and showed more like a bottom-heavy, but also superficial and kind of patchy infiltrate, but it's more down there. You can see the reminiscent of follicles. You can see the small, actually this is kind of irregular germinal center invaded by these small lymphocytes, and high close up you see that they are hyperchromatic. This is the CD20 state, which is highlights the areas. There's a close-up. This is CD3, which is the opposite of the CD20. All these areas are negative. So kappa lambda was actually, kappa was negative, it was lambda restricted. So there was lambda kappa ratio. CD10, BCL6 was negative. And BCL2 is positive in those areas as it's usually positive for marginal zone, and CD43 is negative in those areas. Only the B cells are positive. So but we actually talked to the parents, and we had to convince the parents that observation would be good, and no, for sure, no systemic therapy is necessary. So if they really want, we could consider intralesional steroids or rituximab to the areas, but they were right now very, very subtle, and so they opted to wait. And so we will follow them closely, and every 2 months, sometimes you need to see them more often, just to make sure that they don't have too many lesions, and just for reassurance. So what are the prognostic factors actually in the B-cell lymphomas? Actually, this is the Italian experience. This is from Pierluigi Cinzani, who has actually a large cutaneous lymphoma referral base. They looked into 467 patients. 11 centers in Italy were included over a period of 24 years. So they also confirmed what other European centers in line had shown, that the overall survival in the group of the indolent lymphomas, marginal zone, follicular cell lymphoma were 96% versus 73% in the leg type. The disease-free survival was meaning that the patient had a lot of relapses. It was 57 for marginal zone, 55 for follicular and lymphoma, and 45 for leg type. So it shows, also confirms that you have frequent relapses, but those relapses, and you can see this here in the overall survival, those relapses do not affect necessarily the prognosis and survival. You still have an excellent overall survival. So relapses, however, mean something different here for the leg type. So you do have to, those patients need to be treated more aggressively. They found actually that even with radiation, actually patients had relapses, and with chemotherapy they have a much lesser relapse rate. Surgery was also performed between 30 and 37% of relapses. So currently the recommendation would be possibly a combination of radiation and chemotherapy. So these are the NCCN guidelines for the primary cutaneous follicular cell lymphomas. You can actually, everything applies the same as for marginal zone. Except that you may actually, for generalized disease, you may early on may give more intravenous rituximab just to limit the risk of systemic dissemination, although this is very low, but still a little bit higher compared to marginal zone lymphoma. So for second line, if this rituximab doesn't provide complete remission or frequent relapses, so you consider R-CHOP, but only if you fail all these treatments. And I usually, solitary lesions in these patients, if they tolerate, I recommend radiation in those patients. If it's just a very small papule on the face or on the trunk, I do sometimes inject and follow those patients. This is just an example from our patients. He had a nodule on the back. This was radiated. You can actually see the field. So this might be, this was radiated because this is a larger, really area involved, and this was radiated. So it's quite a large area, as you may consider on the scalp. If it's a female patient, you do have to tell the patient that this induces alopecia, and the hair may or may not grow back. So most likely it's not growing back. But this guy didn't make a difference, but you do see also changes of pigmentation, which can be also cosmetically disfiguring in those patients. This is a patient we just saw recently, has for 2 years this patient was treated for psoriasis. It's not psoriasis, it's actually B-cell lymphoma. It's disseminated on the trunk, and he finally developed a larger nodule that was then biopsied and then showed features of a follicular cell lymphoma. Those patients is actually, this disseminated is an ideal patient to be treated with systemic therapy, so we would treat actually with Rituxan 6 cycles. So this is this is another patient. She didn't want to have any treatment, so my colleague actually treated her with systemic, and this was just published in a review, with clobetasol ointment.